So in your boards, they're going to give you gram stains on your sputum. They'll give you gram stain on your CSF. They'll give you gram stain about anything, so it's a fair game. So know your gram stains well, okay? Because they're not going to ask you what is the bacteria. They're going to ask you how you're going to treat it, what are the complications. You know, they're not going to ask you straightforward answers. So know your gram stains well. Know what is gram positive, what is gram negative. Gram negative is what color? Pink or red, okay? So negative is red. Just remember that, okay? So strep pneumo, gram positive, lancet-shaped diplococci, and probably in meningitis also they can show you a CSF gram stain and show the same kind of picture, okay? I'm not going to go into each specific pneumonia because we'll not have time for doing all that today. So, Marie?
Okay. 60-year-old female with COPD, exacerbation, fever, and yellow productive sputum. Sputum gram stain shows, looks like gram negative.
Good.
Cocci.
And there are 2 arrows there to help you out. In exam, you won't have those arrows. What does it look like? There are cocci and there are what? Morphology, cocci and what? What are the long?
CD.
What did you say? Okay, so that's bacilli, right? So bacilli are long, straight, they're not circular, right? So you're saying cocci and bacilli. What causes pneumonia, which is in both forms, cocci and bacilli?
Hysteria?
H influenza. So that's the answer, H influenza. The COPD patients that are higher risk for H influenza, and if you see a gram stain with both cocci and bacilli, that is H influenza. That's what they are asking about, okay? So remember that, and it's gram negative. So red is negative. Pooja?
30-year-old alcoholic male with fever, cough, sputum specimen, and gram stain on the short and very gram negative, current jelly.
I can't give you more than that.
Klebsiella.
Okay. Current jelly sputum, Klebsiella, okay? Alcoholic patients are at high risk for Klebsiella. If they say current, you have to remember your buzzwords for your boards, okay? Current jelly sputum, or if they show you a sputum like that, which is mucoid and reddish, then you worry about Klebsiella, okay? So remember that for your boards. Gram-negative rods. Rods are long and narrow. Cocci are round, okay? Rona?
35-year-old postpartum septic female with following chest x-ray, history of atypical pneumonia in pregnancy 1 month ago. Diagnosis. So, they're, I guess, gram-positive cocci in clusters.
What is gram-positive cocci in clusters? Your micro always writes that on a report on a gram stain.
Staphylococcus.
Okay, Staph aureus.
Could be chloride positive, negative.
So what do you think caused that? What is that atypical pneumonia if you think this is Staph aureus thing after an atypical pneumonia? This is a Staph aureus pneumonia after an atypical pneumonia.
Mycoplasma?
Like a flu?
Influenza. Okay. So that's a known association. Post-influenza pneumonia, Staph aureus pneumonia. You want to think about that, okay? That there is a connection. Post-influenza pneumonia is Staph aureus pneumonia. So remember that in your boards. You can also see in IV drug abusers, Staph aureus pneumonia, and immunosuppressed patients. Some of the Staph aureus pneumonia are necrotizing, so they'll have abscesses, and they have bullae, and all kinds of things. It's based on if they're producing the toxin or not, okay? But some of the pneumonias can be really bad. Banu?
18-year-old homosexual male with AIDS complains of dry cough for 3 weeks and progressive shortness of breath. PO2 less than 60, LDH was elevated. Chest X-ray and sputum Jim sustain.
It's a silver stain.
Stain show. Pneumocystis.
So that's straightforward, right? AIDS patient, dry cough for 3 weeks. Pneumocystis is something that you won't see acutely. Patient doesn't get acutely short of breath in pneumocystis. Patient is short of breath for 3 or 4 weeks. It has a chronic onset, okay? It's not acute pneumonia. So if a HIV patient is coming with acute pneumonia, then it's probably not pneumocystis, okay? They'll tell you I've been having dry cough. If they're not complaining of shortness of breath, they'll tell you I'm having dry cough for the last 3 or 4 weeks. So it's not necessary you're looking for a cough with sputum production or shortness of breath. They may not complain about shortness of breath. They may just say that I'm having dry cough for the last 3 or 4 weeks. Okay, still it should. And the indirect measure for pneumocystis that we check is LDH. Okay, if LDH is up, now LDH, it can be skewed if there's something else going on, if there's any other inflammation going on in the body, the LDH can still be elevated. But it's not absolute that it always is going to be, up because of PJP only. But that's one of the indirect measures we check when we want to see if this patient has PJP or not. PJP tends to get worse when you start them on Bactrim. Okay, always remember that. So if they don't meet the criteria for prednisone, so what is the criteria for putting steroids on PJP pneumonia? A gradient more than 35,
PO2 less than 70.
Okay. And y'all calculate that when you admit the patient and decide whether to put on prednisone or not in your little phones, right? Okay, so you have to monitor when you put them on prednisone in patients who are borderline, okay? Maybe their A gradient is not 35. Maybe their oxygen saturation is not at the cutoff for steroids. But once you start that Bactrim, they're going to get worse, okay? That's how this infection is, because Bactrim starts killing the organisms, which creates inflammation in the lungs. So their chest X-ray is going to worsen, and they may become hypoxic at that time and meet the criteria. So even if they don't meet the criteria at the time of admission, once you start that Bactrim, if they're worsening respiratory-wise, then have that little radar in your head that they need steroids, okay? And they may need high-dose steroids depending on disease burden in their lungs. If their lungs look really bad, like this person's, then they may have a lot of burden of pneumocystis in their lung, okay? So try to remember that. But AIDS population is not the only one who gets pneumocystis. Other immunosuppressed person can get it too, especially the bone marrow transplant patients.
Jody, I have a
Or
question.
solid organ. Yes.
2 questions. First is the J instead of P. Is this like a different strain, or why did they change that?
They just change hands for fun.
To protect the innocent. Got it. Okay. And yeah, well, just make us look old. And the second question is, what do you hurt if you give somebody steroids? So is it just a better part of valor to just give everybody steroids?
Not everybody needs it as such.
But you can stop it later, right?
Yes, you could stop it, because if a person is going to need, the only problem will be if you start the steroids in the beginning and maybe decide after 2 days that when the patient is ready for discharge that you don't want to continue the steroids, and you discharge the patient on PO Bactrim. When they lose that steroid support and if they go outpatient, you may be masking how severe the infection is, because this steroid will go as a taper with their Bactrim for 21 days if they really need it. If they don't need it, and if we put it just empirically and mask that effect, we won't know whether they're going to need it the whole course. If we start up front, then we may end up, having to give 21 days, rather than, just stop before leaving, and they may end up coming back just because they worsened as outpatient and come back again. So probably it's just better to, if they don't meet the criteria, to just observe what is happening. You should see within 24 to 48 hours if they're going to worsen.
Thank you.
When do we start hard if somebody comes with?
Not when they are in the
Yeah.
hospital.
But when
Not
days
but
do we wait? How long do we have?
at least 2 weeks. At least 2 weeks. Okay. Now sometimes some patients, and it's also in general 2 weeks, but sometimes some patients are stuck on the ventilator, fighting to live, and as an absolute last attempt, we will still try to wait 2 weeks before we put them on antiretrovirals, okay? And we don't like to do it in the hospital just because there's so much going on, there's so many drug interactions going on. We like to do it as outpatient. If we can, and if that patient has enough immune system to get over this episode of PJP, okay? But if somebody's stuck and just battling life and death, then sometimes we may start them on it, but we try to wait, because what does antiretrovirals do when we start a patient on antiretrovirals? It just inflames their whole immune system. So if you give antiretrovirals to somebody who has an opportunistic infection, it's going to flare up. If this patient is already on breathing machine, that means you're giving them death sentence by giving antiretrovirals, because you're going to inflame their immune system, okay? Even those little bit of high-dose steroids that you're giving may not be enough to conquer that, okay? So that's why we hold back.
So for most opportunities.
Yes, for most. Now, if it's oral candidiasis, that's not a life-threatening one. So when I say most, we exclude the small ones. Okay. Marion.
50 years old male cigarette smoker presents with dry cough, headache, nausea, diarrhea, and confusion. Pulse is 60, blood pressure 120/80, temperature 102, that is elevated, sodium 128, occupation installed fountains. Imaging shown that it's showing a lot of junk in the left lower lung lobe, and it's out gas, maybe Legionella, based on those.
So why did you say Legionella?
So,
Because he installs fountains.
because of the diarrhea.
Because of the diarrhea. So you want to think about, so pneumonia is one atypical pneumonia that causes severe pneumonia, community-acquired pneumonia, okay? So it's one of the atypicals that causes severe community-acquired pneumonia. Amongst the atypical, it's the one that causes severe pneumonia. You don't want to miss on this one. The nausea, vomiting, diarrhea, headache, confusion, elevated LFTs, low phosphorus are some of the things that have been noticed. Not all the patients who have Legionella are going to have all the things that are described in the book, but they may have some here and there that may help you to correlate. Any exposure to water source, working with air conditioning, hot tubs, sauna, all those, anything water exposure, there's a high risk for Legionella. So if you're asking them questions, if they're not intubated, and you get some exposure history, then you have to have Legionella in the back of the mind. Here, everybody gets Levaquin, so it doesn't matter, but just as a, well, you're going to get medical students, so you want to make sure you're teaching them why you're using different drugs and what you're trying to cover, right? So with the Levaquin, that's what you're trying to cover when a patient comes with severe pneumonia is Legionella, okay? You check a urine, if you're going to put a patient on Levaquin, make sure you order a urine Legionella antigen if you're worried about a patient who's admitted in the ICU with a severe pneumonia. And you put the patient on Levaquin, and when I round with y'all, and I ask y'all whether you have ordered a urine Legionella antigen, answer I get is no. So make sure you order it. If there is a suspicion, if you're admitting a patient with severe pneumonia to the ICU, then you want to order the urine Legionella antigen.
How good is it?
will detect, it's 80%, so it will detect only genotype 1 though, okay? But that's the one that causes 75 to 80% of the causes of Legionella pneumophila, which causes the most of the episodes in this country. So that's pretty good, I think. We may miss some still, so 21 days. Okay, so it's a longer treatment. So if you don't check, and you discharge the patient and give incomplete treatment or 10 days course, then you're giving a shorter course, then the patient is not going to respond well and may end up back here. Or if a patient has some pleural effusion and is not completely treated with a longer course, then they may end up with empyema and get in here, okay? So have that in the back of the mind when you admit a patient with severe pneumonia and put that patient on that level plan, okay, while you're using that level plan. The other thing that are clue when you're looking at case scenarios in your board exam, usually when you have fever, this patient has fever of 102. With every 1 degree rise in the temperature, your heart rate goes up by 10 beats. This patient's heart rate is 60. They are not giving you any other information. The patient is on beta blocker or anything, so you can read all that stuff. So there are a few things that cause relative bradycardia in infection. Things you may not see everything that is in there, but they may use it as a question stem for some of the scenarios. So Legionella is one of them. Q fever, they can ask you. Typhoid fever is not common in this country, so I doubt they'll ask you about that. Leptospirosis is common in this country, and they will ask you about that. So you will watch out for that there. And Rocky Mountain spotted fever is a fair game, so they can ask you in that. Non-infectious causes, y'all know beta blockers reduce the pulse, so you know that. Drug fever, but I've not really seen in clinical practice as such. With drug fever, I've seen relative bradycardia, so it must be very uncommon if it is there. But remember, those atypical pneumonias that the bugs that you will commonly encounter that you're covering for are Legionella, Mycoplasma, Chlamydia. In this flu season, influenza, you want to have that in your mind, at the back of your mind. If somebody's coming with atypical pneumonia, you should be checking for flu and PJP in certain population. Sam?
40-year-old septic male admitted with fever, chest pain, hemoptysis. Chest x-ray shows, blood culture shows gram-positive rods, gram staining. Gram-positive rods. So, like this dude?
They're long. If you see listeria, if they show you in anywhere, and we're talking about pneumonia, if you see it in the brain, they're small little rods, okay? Yes, nocardia is a gram-positive rod, but it has a different morphology. Boxcar. What does boxcar stand for? Bacillus anthracis. So this is Bacillus anthracis. The X-ray is not showing you much, but it is showing you something that you have to mediastinal widening. They can give you bloody pleural effusion. They can tell you they are saying the patient is having hemoptysis. There are not too many pneumonias which will cause hemoptysis. Okay, tuberculosis. Tuberculosis bacteria doesn't look like that. It would be hard to see it on a gram stain, okay? And it is not that bad. It's very hard to see it even in a smear, okay? So this is a bold, boxy, long gram-positive rod, so you want to remember that. Anthrax is a fair game in your boards. They'll give you clues of mediastinal widening, bloody pleural effusion, or hemothorax, okay? And if they give you this gram stain, you don't have to think too hard. Gram-positive rod, which is long and boxy, is anthrax in your boards. And if they give hemoptysis, bloody pleural effusion, or anything else, then that's what you're looking at. And if you have inhalational anthrax, what does that mean?